Thank you to Kathryn Richardson. She asked me to introduce herself as a palliative care specialist working predominantly in the humanitarian sector. Quite an unusual mix. Kathryn's on our executive and we're delighted that she's going to address us now.
Thank you, Moira. So my name's Kathryn. I'm a palliative care specialist and I want to share with you today 3 short stories from my experience working in the humanitarian sector early in my career and some insights as working as a palliative care specialist within the humanitarian sector. So I started working with MSF 12 years ago, and my first posting was to Bangladesh to work in a primary health clinic with an inpatient pediatric unit within the refugee camp for forcibly displaced Myanmar nationals. Severely malnourished children would be admitted daily to our inpatient unit with severe infections, usually with pneumonia or acute watery diarrhea. They would be given F75 therapeutic milk and antibiotics, and when their infection had improved, their care would be transferred to a nutrition NGO whose centre was next to ours, and the child would continue in the nutrition programme. Once the child's malnutrition was classified as moderate rather than severe, the child will be discharged back to their home in the camp and continue with supplementary feeding with Plumpy Nut. Several weeks later, the same child would be readmitted to our inpatient unit, again with severe malnutrition and severe infection. It turned out the Plumpy Nut had been shared with the other 12 hungry siblings in the home, and the child was again very sick. And this vicious cycle of severe malnutrition and severe infection we saw in so many of the children who were admitted to our clinic. And I remember feeling powerless to make a difference. But I also had the realization that the most important work we were doing in Bangladesh was to be there, to bear witness, to show that child and family that they matter, that they were not being abandoned. So there are common principles shared by palliative care and humanitarianism. Both share a similar ethical framework, and both engage people with a similar drive to respond with humanity and compassion to relieve human suffering. Both are interested in maintaining dignity, in helping the most vulnerable, and being there for people through difficult times. And this overlap of goals and ethics represents a great opportunity for integrating palliative care into humanitarian response. I later worked in DR Congo. Patients would present with advanced disease. I remember one man presented with a large head and neck tumour at the site of his mandible. He was severely distressed, and his face displayed the agonising pain that he was feeling at the site of the tumour. We had little to offer, no surgery, no anti-cancer treatment. We prescribed regular tramadol and asked the man to return after 1 week. When the man returned, I barely recognised him. His face was relaxed, he was smiling, he looked peaceful. His pain had improved, and he repeatedly thanked us for helping him. So simple palliative care interventions can have a big impact for patients and families. And while we felt we had little to offer for this man with a tumour, by relieving his pain, by relieving his suffering, we had a huge impact on his quality of life. I remember caring for a young woman with advanced HIV and TB. At the time, we were waiting to have access to antiretroviral medications in the project. There was stigma associated with HIV. The Congolese doctors asked us not to write the diagnosis HIV in the medical notes because the staff would talk and the community would find out this lady's diagnosis. This young woman was approaching death. The team and I battled on with more IV cannulas, more antibiotics, hoping to avoid death, hoping to avoid what I felt was failing her. We did not succeed. I, like so many doctors working in humanitarian response, focused on life-saving interventions, even if they had little or no hope of being effective. I did not know how else I could help. After working in the Congo, I wanted to learn better how I could respond to the suffering I had seen. I moved to London and I started training in palliative care. Within weeks, I had gained skills and knowledge which would have enabled me to respond much more effectively to this suffering. So these are my experiences, and I know they're shared by so many who are trained to save lives, but do not know how to attend to the dying and chronically sick. These are my stories, but these projects are still running more than 10 years later. And while many patients have had access to medical care, thanks to medical humanitarian organizations, they were not able to access palliative care. So we have a great opportunity to integrate palliative care within the medical humanitarian response. There are comprehensive medical humanitarian operations in most humanitarian crisis settings, meaning there are resources for implementing palliative care, meaning there are doctors, there are nurses, there are mental health teams, there's medication supply, and there are healthcare facilities. So medical humanitarian organizations respond to different types of crises. Epidemics, conflicts, and disaster response are all associated with high mortality. But most humanitarian response is to more protracted crises that may last for many years. In protracted crisis, the pre-crisis care for patients with life-limiting illnesses may have been interrupted, and for many patients, that care may just not have existed pre-crisis, meaning that many more people may need to access palliative care. Vertical projects may also be associated with high mortality in some settings, for example, advanced HIV, MXDR-TB, and neonatal projects may all benefit from having component of palliative care. And we know that populations who have been forced to migrate have also been shown to have high palliative care needs. Next slide. So what might palliative care in humanitarian response look like? And as Joyne says, we do have examples of people doing wonderful work already internationally. But the palliative care in humanitarian response, as I see it, needs to be simple and clearly defined so that we can reasonably expect it to be integrated within the medical response. So we can think about palliative care as having different components of care, and the medical program can integrate different components of palliative care depending on the needs of the population being served. For example, we can think of symptom control as a component of care, and we can introduce simple assessment tools to help with symptom screening, symptom assessment and symptom management for physical and psychological symptoms that are commonly seen in patients with advanced disease. We can think about supporting patients and families through progressive illness and end of life, and think about giving teams the skills in communication, counselling, meaning emotional, social, spiritual support, and care planning to help them to do this. And we can encourage multidisciplinary team working to aid decision making and provide support to doctors who are making decisions about whether to continue active treatment and making decisions about ceilings of care. And we can encourage palliative care in parallel with active disease management, and aim to dispel the myth that palliative care is just care in the last hours and days of life. So while there are many challenges to integrating palliative care in the humanitarian sector, there is a cause for optimism. As Joan mentioned, in 2018, the WHO produced the first programmatic guidance on how to integrate palliative care and symptom relief into humanitarian crises. And in the same year, the Sphere Handbook included for the first time a chapter on palliative care. Within MSF, we've started to integrate palliative care into neonatal, advanced HIV, and NCD projects. And we've just completed the first guideline for MSF on palliative care. And we're designing some training programs in palliative care for field staff this year. Also within MSF, we've produced guidelines on symptom control and communication at end of life for field teams responding in the COVID pandemic. And I know other medical humanitarian organisations are also turning their focus to guidelines and training for their field staff. We're at the very beginning of learning how to integrate palliative care into humanitarian response. And we need to learn through research in the field how we can do this most effectively. We need advocacy to raise awareness for palliative care, and we need advocacy to improve access to immediate release oral morphine, an essential medication to providing palliative care. So in summary, we have a great opportunity to introduce palliative care into humanitarian response. Palliative care and humanitarianism share similar principles, meaning that humanitarian health workers' attitudes and hearts are focused on relieving suffering and providing compassionate care. We need a model of palliative care that is simple and clearly defined so that it can be integrated within the medical response in humanitarian crises. Palliative care in humanitarian response is in its infancy, and we have a long way to go before patients and families living through humanitarian crisis can have access to palliative care. I hope the narrative of future humanitarian healthcare workers can reflect on how they were able to help and not how they felt they failed patients and families facing chronic illness and death. Thank you.
Thank you so much. That was incredibly helpful and very clear. And I think both your own personal journey as well as those conclusions that you've given us, showing us the similarities and the opportunity